Boa tarde a todos. Nós estamos iniciando mais uma sessão nesse Congresso Internacional de Cardiologia, Encontro Internacional de Cardiologia, Congresso Paranaense de Cardiologia, avisando a todos que aqueles que têm dificuldade com as apresentações em inglês, que há tradução simultânea, então podem pegar os equipamentos aí na entrada, estão à disposição. Nós teremos aqui uma sessão de casos clínicos ao redor do mundo, com as dificuldades, desafios em cardiologia em vários países que serão apresentados aqui. Ao meu lado está o Dr. Luiz Eduardo Mastrocolla, e que já é conhecido de todos, e que vai coordenar as discussões desses casos. Então, sem mais delongas, nós vamos chamando um a um os apresentadores. E the first one is Dr. Stephen Stowers. He's from New Zealand, and his local region is Vanuatu, which means the silent heart. And to silent our hearts, he will speak for us.
Thank you. Today I'd like to talk about some clinical case challenges in New Zealand. And the first challenge is understanding which flag is New Zealand and which flag is Australia. Do you know? When I was introduced by Joe, he sent me the program, and he had the flag on the top here, which is Australia, as New Zealand. We got to change. This is New Zealand. It's the Southern Cross, 4 red stars. And it's been such a problem. This is our former Prime Minister, John Key, who proposed changing the flag because he got tired of going to international meetings and being represented by the Australian flag. But he was unsuccessful. They kept the flag. So today I'd like to talk about a 63-year-old retired gentleman who was getting exertional retrosternal chest pain and presented to our emergency department with negative troponin and no EKG changes. His pain was brought on by exertion, relieved by rest, so it was very typical. He was put on aspirin and statin because of high LDL, and subsequently had a treadmill exercise stress test, which showed no dynamic ECG changes, but had reproduction of his retrosternal chest discomfort. Does anybody want to read this electrocardiogram? So this is an interactive clinical case presentation. Anybody want to yell something out? Right bundle, left axis. Right bundle, sorry, left axis. So he exercised 7 minutes and got the onset of typical anginal pain. But we don't see any diagnostic ECG changes and fairly maximum, 85% of age predicts maximum heart rate. So we did a risk stratification with a calcium scan, and this is done by a computerized software method called the Agassiz score, or the Agassiz equivalent score, where the 3 coronary territories are outlined. Left circumflex in the AV groove, LED, and right coronary artery. And then, based on 130 angstrom units, is assigned a score. And this gentleman's score Agassiz score was 8, which is quite a low score. He had some calcium in the circumflex and right coronary artery. But interestingly, his SPECT MPI study showed a severe perfusion defect in the infralateral wall, which was completely reversible. So he underwent coronary angiography, and the right coronary artery was free of obstructive disease. But you can see in the left circumflex, here with the red arrow, he has a critical stenosis, sequential critical stenosis of greater than 90% in the left circumflex. So one thing that I want to stress to the students here is when you look at a 12-lead electrocardiogram and you stress a patient, the recovery phase is also very important, because what happened in this patient's recovery phase was he developed ST depression, very clearly squared off millimeter ST depression in V4 and V5, which was missed. The ECG was called normal, but in reality, in reviewing it for this presentation, I saw that he had ST depression in the anterolateral leads. And they didn't pick up any calcium in the LAD, but visually, on reviewing the scan, there appears to be some calcium in the LAD here, which falls below the threshold of 130 Hounsfield units, so it wasn't picked up. But visually, it looks like there's early calcification of the left anterior descending. And that correlates with a critical stenosis in the LAD. So look at your ECG recovery phase and don't completely depend on the Agassiz score. Look visually. We've been scoring our hybrid attenuation correction CT scans visually using a Shamish score, which is an ordinal scoring system. So we would have scored the LAD as a 1 in that segment. And through the magic of percutaneous transluminal coronary intervention, you can see that he had excellent result with stenting of the circumflex lesions and the left anterior descending coronary lesion. And now he's asymptomatic and traveling back to India to see his family. So one of the teaching points, other than the ST depression in the recovery phase and the coronary calcium visual interpretation, is that a coronary calcium score of 1 to 10 is often minimized and described as low risk. But in fact, the matter, if you look at the statistics, it nearly doubles the 10-year risk compared with a baseline score of 0. So it's not the power of 8, it's the power of 0. Thank you.
Thank you, Dr. Stowers. With the word to the Dr. Mastrocolla to conduce this discussion.
Thank you, Dr. Stephen. Just a little bit, Dr. Adel. Is there someone here who wants to address a question to Dr. Stephen? Please. Dr. Claudio Tinoco, Dr. Rafael. Dr. Stephens this morning gave us a brilliant speech about the power of the zero. So not is the case. Alguém quer fazer alguma pergunta? Por favor, se identifica.
Stephen, great case. I'm just curious from your perspective, this patient presented with pretty classical angina. So the pretest likelihood we would believe to be very high.
Yes.
So I definitely recognize the importance of CT, and I use it all the time, and a lot of people who have atypical or not so typical pain. But for a patient with classic symptoms, where you're pretty confident they have disease, why would you not do the perfusion scan as the first scan? Stress perfusion.
I would, but I didn't see this patient. And he was referred to me, and so we have a protocol, and if the patient has stable anginal symptoms, they're not typical, which was not the case in this patient, we do a screening calcium score, which in this individual I don't think was appropriate because he had typical anginal symptoms brought on by rest, brought on by exertion relieved by rest. And so I would have gone straight to functional study. I agree.
Júnior.
Congratulations for your presentation, Dr. Stephen. And my question is, recently in the Society of Nuclear Medicine Imaging meeting in Anaheim, there was a discussion about the power of zero with CT as a gatekeeper to myocardial perfusion imaging. And at that table was Marcello De Carli and Daniel Behrman. And what they said is, at this moment, we don't have enough prospective data to use this information in patients with moderate to high risk of coronary artery disease. My question is, a patient with chest pain, angina, typical angina, and you have a zero calcium, you stop the investigation with that. It's not cardiac disease, you do not MPI, you don't do the CAT scan. This is my question.
So I kind of answered this question this morning in my presentation. I think that there is some hypocrisy in the society. The initial recommendation by the NICE guidelines was to use calcium scoring as a screening tool if there was zero calcium. And there is no prognostic benefit demonstrated in a zero calcium score versus a normal coronary CT angiogram. So I think there's some disconnect there between the data and what the recommendations are. And I don't know, I agree that there's not enough prospective data. There is a lot of data on the negative prognostic power of a zero calcium score. But I think there's a lot of political pressure with the Scott Hart study and CTA angiography proponents to say that you should go on to do CTA even if you have a calcium score of zero, because you don't want to miss the 1% incidence of non-calcified plaque. But the problem is it's a little bit of hypocrisy, because we've been doing stress tests in chest pain patients out of the emergency room, and the negative predictive power of that is only about 90% or 85%. Yet nobody has attacked doing treadmill stress testing out of ED, but so there's some disconnect to me in the thread of argument about calcium scoring, especially calcium score 0.
We have, thank you, very nice case actually, and you highlighted the importance of revising the ECG data. Can I have the resting ECG, please? Because I have a comment. In the presence of the right bundle, it must be associated with secondary T-wave changes, right? But if we have primary T-wave changes, it indicates there is underlying ischemia. Can I go back to the slide?
Quer passar de novo o slide dele, por favor?
To the resting ECG.
Do eletrocardiograma. Logo nos primeiros.
No, before. Before this.
Okay.
There.
Okay.
No, before. Yes, this one. Yes.
Okay.
Yes.
Yeah, that's the resting ECG.
Yes, this is resting ECG. When we look to the right bundle branch block pattern, in V1, it's classic right bundle branch block pattern. Here RS, R dash, with T wave inversion. It's classic right bundle branch block. But look to V2 and V3. Here the T waves upright, and still we have, especially in V2, RS, R dash pattern with some elevation of the ST segment. It might indicate there's underlying ischemia. It's one of the signs in the ECG.
Thank you.
You're right.
Let's go to move to the next presentation. Dr. Adel, please. Is it going to be a mummy that you are going to present? This morning, Dr. Adel gave us a brilliant and fantastic presentation about the mummies. We would like that you do repeat this presentation, okay? If you in 10 minutes, please.
Well, I'll try to go as fast as possible. I'm going to be talking about some challenges that we face regarding the patient population in Egypt. So when a healthy person in the prime of his life die or become disabled without warning, this has catastrophic consequences for the person, family, friends, and occupation. Fortunately, most of the studies showed that in individuals under the age of 40, the incidence of a myocardial infarction and symptomatic CD is as low as about 3%. However, we are seeing cases in Egypt with a very young age. So Mr. M.A. is a 30 years old male with a history of a myocardial infarction. He came to us for a perfusion scan after his MI, complaining of shortness of breath. His dyslipidemic with no other risk factors was beta blockers and Vesteral, statin, ACE, and antiplatelets. His resting heart rate was 109 beats per minute, resting blood pressure 130/90. He had Q waves in his lateral leads, ST segment wave changes in his inferior leads, and sinus tachycardia. The patient exercised for 6 minutes, 58 seconds. Stage 3 Bruce protocol. The test was terminated because of severe shortness of breath with no chest pain. He reached a peak heart rate of 162 and a peak blood pressure of 150/90 and showed further ST segment depression with further ST segment elevation in V2 to V6. And this is his perfusion scan. And now you are going to see some heroic cases because this is what we get back home. And I'm going to show it in all different color. He has a very big perfusion defect in his anterior wall, which is only reversible in the basal part of the septum, the basal part of the anterior wall, and the anterolateral. And another huge defect in the mid-lateral wall, infralateral and inferior, that is totally reversible. This is in the GE color scale, and this is in the gray scale, and this is his polar maps. And I think you can appreciate how severe this guy who is 30 years old having a disease. And now we are showing his ejection fraction at rest and stress. And I don't know how to start that. I'll try. So this is supposed to, yeah. So you see that there is regional wall motion abnormalities in his anterior and lateral wall, and a lesser abnormality on the resting study. This is a 2-day protocol, but the ejection fraction remained 30. This means that he has a lot of hibernating myocardium. Very critical multivessel disease with an LED with a thrombus containing lesion. And I want you now to tell me what is the age of somebody who has a coronary angio like this. Would you believe that somebody would have aggressive atherosclerosis to that extent in that age? Anyway, I'll move. Another patient, 35 years old, again history of myocardial infarction and a primary PCI, chest pain, dyslipidemic, smoker, on optimal medical therapy. And again, he exercised poorly, 4 minutes and 15 seconds, had severe chest pain, and had ECG changes. And this is the perfusion scan. Again, 2 large perfusion defects, one in the anterior wall, the anteroseptal, the anterolateral, totally reversible, the other in the infralateral segment and the inferior segment, totally reversible in the midlateral wall and infralateral, and partially in the inferior, with exercise-induced dilatation. So, again, in the 3 different colors, and again, the myomap here showing the very large perfusion defect in the territory of the LAD, and another defect in the area of the RCA or the circumflex, or the 2 together. And I hope I can work this too. And the ejection fraction goes from 36 to 50 on the resting study, and the regional wall motion abnormality is not there anymore on the resting study, so as if you're doing stress echo. Critical RCA thrombus related to the inferior STEMI, and a tight mid to distal LED. And again, I want you to look at this coronary angio of the 35 years old and how aggressive the disease is. But this is what we are seeing in our country, very aggressive premature disease. So the answer is, so we want to answer, why do we have this situation in Egypt? And Dr. Alia in the next session will be showing you this acute coronary syndrome registry that we have done, around 4,700 patients. And when we looked at patients below 45 years, they were 14% of the total population. They are mainly males, mainly presenting with STEMI. The conventional risk factors are lesser in the younger patients, but the smoking is higher and the drug abuse is higher, and they usually present with STEMIs. When we looked at 4,000 patients approximately from our nuclear lab, we again found the same for patients younger than 40 years. Again, premature family history, smoking, and presenting with infarction was the predicting factors. So younger patients are more likely to present with a STEMI in context of the use of tobacco or cocaine, and that prevention strategies in individuals below the age of 40 in Egypt should target tobacco cessation and cocaine cessation, and we should look for individuals with premature family history because they should be diagnosed early, because this is very serious. I'm going to jump to another problem, which is the very large perfusion defects and the amount of the ischemia that we have. So this patient is older, he's 59, he has chest pain, and again, he's on optimal medical therapy. He exercised very poorly, got severe chest pain and SOB, didn't reach a good heart rate, and had severe ST segment changes. And as you can see from the study, again, there is large perfusion defects in the apex, the anteroseptal, the anterior, the anterolateral, the midlateral wall, and the inferior wall. So predominantly everywhere we have ischemia. And the question is that this patient is stable. Should he be revascularized or not? We usually revascularize patients to get better outcome regarding the mortality and the morbidity and better quality of life. But the Courage trial and the Berry 2D trial showed us that there is no improvement with revascularization. From the classic observation data that we have, we know that above a perfusion scan, above 10% would do better, the patient would do better with revascularization. So we elected to do a mini ischemia trial. The aim of the study was to determine if patients with stable CED and large reversible defects on SPECT MPI benefit from revascularization. We took patients from 10 months from the year 2012, around 2,000 patients, divided them into whether they have normal study, around 55%, 20% had defects lesser than 10, and 16% had defects more than 10 but predominant scar, and 11%, 213 patients, had large defects but predominant ischemia, and we define that as a large defect more than 10 with the ischemia at least 8 or more. And if you look at the patient characteristics, they're very young, they're predominantly males. Hypertension 40%, dyslipidemia 81%, diabetes 56%, smoking 62%, previous MI 17%, previous revascularization more than 40%. They look to be on optimal medical therapy. We followed them for around 4 years. We did manage to get 201 out of the 213, 94%. There was no difference between the follow-up group and the group that were not followed up. And if you look at the size of the defects, the sum stress score, mean 19, the sum stress score, mean 3.9, the sum difference score is 15. And the ejection fraction at rest was borderline 49. So when we looked at the management that they got, this is a retrospective observational study. 62% underwent revascularization, mainly PCI, 91 patients, and 38% of the patients stayed on medical management. When we looked at the medical group versus the medical with revascularization, the medical group was a little bit older, but still very young, 58 years, and the medical and revascularization group had more myocardial infarctions than the other group. When we looked at the variables of imaging, they were exactly identical. And of course, again, very large defects, mainly reversible. And those are the Cox regression adjusted curves. And you can see that since the beginning, there was excellent separation and very big separation between the ones who got revascularization opposing the one that had medical therapy alone. This was true for cardiovascular death, non-fatal MI, cardiovascular death alone, non-fatal MI alone. Of course, there is a limitation for the work. It's an observational retrospective study. It's a single center study, small number of patients, and adherence to medical treatment throughout the follow-up period cannot be ascertained. But we can say that in Egyptian patients and in Egyptian hands of the revascularization cardiologists, with large ischemic perfusion defects, revascularization is strongly associated with fewer heart events and cardiovascular deaths in the current era. This is an observational study that demonstrates that significant ischemia detected on MPI is an important prognosticator and allow direction of therapy in patients with stable ischemic heart disease. And thank you.
Thank you, Dr. Adel. Let's discuss this case.
We have time for one question. Dr. Billings, please.
The patients that you have, the young patients, do they have, what is their risk factor profile? Do they have strong family history? Do they have diabetes or pre-diabetes?
The only thing is smoking.
Smoking.
Yeah.
Yeah.
So the problem here is that this is not the usual pattern for smoking or drug abuse. The usual pattern for smoking and drug abuse, when you do a coronary angio, that you see endothelial denudation or ulceration, and just a thrombus that would be removed just by passing the wire. This is what usually invasive people tell us. And the arteries usually look very clean. But those, they are extensive, aggressive atherosclerosis that is really looking like as if the patient is 80 years old. So I think there's a genetic thing here, and we need to do our homework more.
I have a comment. Congratulations for your work. And recently, the Boston group published a paper in JACC using PET-CT of the vascular inflammation and the brain. And I believe the Egypt and Brazil are facing some common problems, because in Brazil I have some economic problems and violence. And in this paper, they correlated the violence and the low economic status with increased vascular inflammation and the severe coronary disease. Do you think that this can be a contribution?
This again could be an unconventional risk factor. We had a revolution in our country. We have economic problems. It's much better now, thank God. But I have been practicing nuclear cardiology for the last 30 years. And we have been seeing that for quite a while.
Do you think that these results that you showed will be extended to the ischemia?
Hopefully.
Okay, thanks a lot. Let's gonna move to the next.
Please, Dr. Felix Keng, from Singapore. Singapore is called the City of Lions, so you're here to defend our hearts.
Okay. All right, thank you, chairpersons. Okay, I'll just present it's a dilemma both of management and treatment, okay? This is a 58-year-old Indian gentleman. He's a brain operator. The only risk factor he seems to have is hyperlipidemia. He's otherwise okay. Now, he comes to the ER, and these people who come to ERs, they are a self-selected group of people who are worried about whatever symptoms they have. And of course, in this case, he has been having chest pains on exertions and also at rest, described as central and left-sided, tender chest wall to the touch sometimes, some compressive symptoms as well. He gets them at rest too, but when he climbs an overhead bridge, he gets them more. So this is, what we would call maybe typical and atypical chest pain symptoms. Okay, so in the ER in Singapore, we will just monitor the patients for up to about 8 to 16 hours. In this case, the ECG looked perfectly bland. It was normal. Chest X-ray, routine bloods, all okay, all normal. Okay, troponin Ts were all flat. CK and MB fractions were all normal. So monitored as for a chest pain protocol. So what I would ask the audience right now is, what would you do next? Would you discharge the patient? Discharge. How many says discharge? With no further follow-up. Good, no one. I could get a show of hands, that would be good. Would you like to do a treadmill exercise test? Okay, quite a few. How about something better than a treadmill exercise test? Something like a perfusion scan. Not that many. Good. How about CT scan instead? Okay, a few as well. So we have quite a few options here. Okay, I don't think there's a right or wrong answer here, but we decided to do. Okay, so that was what I was going to ask you, right? All these things. Anybody want to do the invasive procedure straight away? I hope not, because it's clearly not indicated in this case. Okay, great. We're all in agreement here. This is what we did. I will not show you any ECGs during the treadmill exercise test, but he did complete his required heart rate. He got 100% of the targeted heart rate. The ECG remained bland, remained negative electronically or electrically for ischemia. This is his perfusion stress and rest using a sestamide same-day protocol. So what do you think? Okay, these are the options. Normal. Only one? Wow, okay, abnormal. Okay, 0. So the rest of you don't know how to read it. Okay. All right, let's let you have a look again. Oops, sorry. Okay. It looked pretty normal to me. Actually, I'm the person who read this scan. So in the end, I kicked myself in the backside. But okay, this looks normal.
Again, there is time.
what, somewhere here? Okay, all right, sorry, this mouse is not very good. Okay, well, I called it negative for ischemia. Okay, so discharge the patient, but fortunately for ER patients, we don't discharge them totally. We send them to a cardiologist, one of my colleagues. Okay, so sent home from the ER with an appointment to see the cardiologist in 2 weeks. Upon review, you ask the patient, how's your chest pain? It's still there. It's as bad as before. Probably not worsening very much, despite all the analgesics we gave the patient. Didn't give the patient anti-anginal therapy. Okay? Neither did we give statins, neither did we give aspirin. Okay? All right. So, what shall we do now? Reassure and discharge. Good. Further testing, but further testing with what? Okay. Who would like to do CT scan? Okay. Who would like to do MR? Okay. All right. How about just good old angiogram? No. Okay. Well, the aggressive people may just straight away and do an angiogram because of continued symptoms. Okay. Or maybe it's in the mind, so you refer to a psychiatrist or a psychologist. Okay? No, none of us do that. Okay, so what we did was this. A CT scan, CT coronary angiogram. If you had proceeded just to do the calcium score, it was 158. And that's, he is 58 years old. So that's probably about nearly the 90th percentile. Okay, so it's high, but CTA was done. And I was the poor person who also interpreted this CTA. That's why I say I kicked myself in the buttocks. Because my nuclear scan perfectly normal, my CTA perfectly abnormal. But how bad is it? Okay, and which artery is this? Well, this is left main actually. Quite a lot of mixed plugs, a bit of calcified plug, but majority mixed plugs. So the calcium score was not very high. Okay, but if you had looked at it, I actually called it moderate. That means 50% to 70% stenosis. And also further up in the LAD, looks like there's a lot of disease here, probably moderate to severe as well. This part. Okay, so lots of disease. Now what am I going to do? Okay, who will say CTA is normal? Obviously not. Okay, everybody says CTA is abnormal. But how abnormal? Is it abnormal enough for us to want to intervene? And of course the question would be, the cardiologist calls me up and asks me, what's wrong with your MPI? How come you could not detect? Well, the usual reasons, right? There is no significant blood flow abnormalities. Maybe I just got it wrong, etc., etc. Okay? So, obviously we sent the patient, because of this left main disease that was moderate, we sent him for the angiogram. And this is the angiogram. Look at that left main. To the untrained eye of mine, it doesn't look that bad. Okay, but do you think the LAD is diseased? Because it's there. Okay, it's pretty bad. Okay, and hold on, let's see. Okay, if I scroll, oops, can't stop it. Okay, I can stop it. So, very bad disease in the proximal LAD. The left main didn't look that bad. Okay, and this is the right side. No, sorry, this is not the right side. This is just another view. I'll move on to the right side, which is, well, a small right coronary artery. So, okay, what are you going to do now? Who would say, put in some stents? Who would say, send him to the surgeon? Nobody wants to send to the surgeons. The surgeons have no business anymore. Okay, so, we spent too much money already. So the interventionist says, no, I don't need the FFR. It's so obvious. let's just stent it. We actually asked the surgeon. The surgeon said, oh, it's only one artery. If I just put in a lima to the LAD, it's quite a waste. The circumflex and the RCA doesn't really need much intervention. So the interventionist very happily, of course, would intervene. And this is the intervention and post stenting all the way from the from the left main, middle to distal left main to the ostial and proximal LAD. Now it looks very pretty, right? Looks very nice. Anatomically, it looks nice. Okay. All right. So what do we do next? Well, okay. Now the CTA. How good is it in picking up significant disease? Okay. So the left main was the clinching point. We wanted to intervene because of this left main, but it really did not look very bad on invasive angiography. Okay, all right. But this is not a dilemma. Follow up. Okay, we give them lots of medical therapy. How do you feel now? This was about 2 months after. I feel exactly the same. No resolution of symptoms. In fact, now I feel worse because you gave me so many medicines to take. Okay? It is to be continued because I just saw this patient not so long ago. So, did we do the right things? I don't know. If we did the right things, we did not solve his symptoms. So, now I will stop here and invite any questions that you have. And this is a family of otters that live in Singapore. Would anybody do things differently?
I have a question. After the angioplasty, we had this flow. It was very slow, I think.
Can I go back to the slides?
Quer passar os slides dele de novo, por favor?
I thought it was sort of like pretty good Dimitri kind of flow. Okay, but let's have a look. The interventionist was quite happy actually. Can I control it? Okay. So this is... Okay, this is the post, right? Okay, I don't know. Well, the interventionist was happy. But whatever it is, the symptoms did not rebate. So, maybe I can show you the other view. What do you think? It looks pretty good to the untrained eye of mine again. Well, if you said it didn't work, then, this is a dilemma. Nothing seemed to work. Okay, but remember the perfusion scan was like pretty normal. And if you say inferior wall, it's the wrong territory. Yeah, so, no. So it is a dilemma. Now I'm going to send him to the gastroenterologist to look for gastric problems. Yes?
It's a great case, Felix. Actually, the one test that I think might help would be flow quantification. It's the one piece that's missing, and although there's a couple of the angles of the angio, I am still a little troubled by the left main, and certainly the CTA of the left main was concerning.
Right.
So if we're looking at, and I think the right was non-dominant, wasn't?
Yes, it was.
So you could still be looking at global reduction in flow that's missed by the relative perfusion on SPECT, right? So flow quantification with PET or potentially with SPECT or on other methods might help you tell.
Yeah.
Again, the other piece is the patient's pain really cardiac or not? Like that's,
correct.
I think, referring to other possibilities, and always have to be careful when you're uncertain that you're explaining that to the patient as well, so that their expectations are managed as well.
So, well, this patient is, not so happy now because we've done so many things and we didn't really solve his problem. Yeah. Okay.
Okay.
Thank you very much.
Okay, thank you. Dr. Billings, please. Very challenging cases today.
Thank you. I'm going to, how do I get started here? In here? Okay.
Forward, backwards, and legs.
Yeah. Okay. I'm going to switch gears a little bit, and again it'll be interactive. I have a couple of cases. We'll see if we can get through one or two of them. We have no issues with our flag. It's quite distinct from the United States. It used to be hard to distinguish from Australia and New Zealand. Yes, now it's quite distinct from the United States. These are my conflicts, and the other conflict I have is that I'm president, although I'm Canadian, of the American Society of Nuclear Cardiology. And just to remind people about the upcoming meeting, please attend. It's a great meeting, or sign on online. So, we'll begin with Allam. We're changing gears completely here, okay? So he's a 44-year-old man, he's a paramedic, working in Afghanistan, who presented with burning and pre-syncope and developed complete heart block and was brought home to Canada. What disease are we thinking about here? Anybody? So the question is, should this patient have a workup for cardiac sarcoidosis? Show of hands. Anybody think that they shouldn't? Okay. So the situations in which cardiac presentations can be the first and/or an unrecognized manifestation of sarcoidosis are idiopathic advanced conduction disease, unexplained high-grade AV block in younger patients. Younger than me, I'm 60. So anybody who's younger than me who has AV block has about a 25 to 33% chance of having underlying cardiac sarcoidosis. Sustained monomorphic VT that's unexplained, ARVC, it can be mimicked with sarcoid, or idiopathic heart failure, uncommonly but also possible. So here's the scan, the PET scan on this patient. And I'm going to ask 3 questions. Does this patient have cardiac sarcoid? Yes, probably, not certain, or no? Yes, does the patient have cardiac sarcoid? Probably, uncertain, no. Okay. So along with that, we would ask, should the patient have a cardiac biopsy? Should the patient have an extracardiac biopsy? Extracardiac biopsy, okay. So FDG PET is pretty accurate for the detection of cardiac sarcoidosis. With this older meta-analysis, sensitivity is around 90 and specificity around 80%, probably even underestimating it. But it's not 100%. And it's not a specific diagnosis for sarcoid. The patterns that we're looking for are focal or focal and diffuse. And we also want to consider perfusion, and as that can indicate potentially worse disease. As well, we now know that FDG and MRI as advanced imaging methods are part of the guidelines, both the new Japanese Society guidelines and the Heart Rhythm Society position statement on cardiac sarcoidosis. And as well, the recommendation is that if the initial screening tests are suggestive of sarcoid, which is the case here, biopsies can be useful, and biopsies should be extracardiac first if feasible, otherwise guided endomyocardial. I'm just going to go back quickly to the images, and I'll just point out a few things. So you see that there's myocardial FDG uptake. We always do whole body imaging, and we co-read these between our cardiologist and nuclear medicine physician. I think each provides a level of expertise about the disease and about the imaging that helps us with these patients. You can see that there's actually extracardiac sarcoid as well. The perfusion is relatively normal. There's FDG uptake in the septum and the inferior wall. You see as well some towards the apex, some in the right ventricle, and even some in the atria. So back to our case. So as I said, PET is consistent, but we can't make the definitive diagnosis of sarcoid. It's consistent with active cardiac sarcoid and active systemic sarcoid. The patient did undergo a lymph node biopsy, which was non-specific, and then subsequently had a cardiac biopsy, which was positive for sarcoid. So should this patient have a pacemaker? Presenting with AV block and cardiac sarcoid, pacemaker? Everybody? Yes. Should they have an ICD? So should the device be a defibrillator? It's a more difficult question. And should the patient be put on corticosteroids? Yes. Okay. So we know that in the presence of cardiac sarcoid, the risks of VT, VF, or a sudden cardiac death are significantly increased compared to those with just episodic cardiac sarcoid. So when you have a diagnosis of sarcoid, cardiac sarcoid, you should be thinking about device therapy. We also know from this prospective study from Ron Blankstein and Marcello De Carli and others in the Boston group that the degree to which there's abnormal perfusion and FDG is a predictor of adverse outcomes. The recommendations from the Heart Rhythm Society are for these patients, in addition to the usual indications for devices, that it can be useful in cardiac sarcoid patients if there's already an indication for pacing. So in this case, the patient should get a defibrillator, okay? We definitely know there's a pacemaker is indicated. Immunosuppression therapy can also be useful in cardiac sarcoid presenting with high-grade AV block. And ICD implementation can be useful in patients with cardiac sarcoid and it indicate when there's an indication for a permanent pacemaker. So the immunosuppressive therapy, there's not very good data. It's used empirically. There's no randomized trials. We're actually conducting a randomized trial of steroids versus methotrexate in these patients. The only group where there actually is good evidence for outcome benefit in meta-analyses, again, of retrospective and prospective data is with patients with AV block. However, we all do use steroids when there's a high degree of inflammation with FDG. So an ICD was implanted. The patient, though, was quite nervous about the risks of steroids and declined steroid therapy. 6 months later, he presented feeling less well. His LV function was normal earlier, and now EF has dropped to 30%. We repeated the PET and recommended starting steroids. And here's the repeat PET scan. You can see much more FDG uptake throughout the myocardium, still patchy, but much more extensive. Interestingly, somewhat less extracardiac activity. You can see also now there's some perfusion abnormalities and more extensive FDG. And lo and behold, the patient did have a cardiac arrest, but fortunately had an ICD in place. Okay, so again, the message back that these patients should be getting device therapy. I'll put to you as well from the Heart Rhythm Society their recommendations for patients who are being considered with cardiac sarcoid, screening young patients who are under my age with acute presentation of idiopathic advanced conduction system. FDG is the first test suggested. When you're screening for cardiac involvement in patients with extracardiac sarcoid and they have one other feature, such as syncope, ECG, or Holter changes, MRI is the test of choice. To follow up on the responsiveness to steroids and immunosuppression, FDG, and to look at patients who develop VT as a manifestation of sarcoid when it's already been treated, FDG PET would be a recommended choice. So with just a couple minutes left, I'll go over another case. This is now a 24-year-old woman who presented to the ER with palpitations and retrosternal chest pain. She had a troponin elevation and a positive D-dimer, but her PE on CT was negative. And then she was sent home, and a few days later, this was her ECG. Alia?
Yes.
What do you think?
I think the ST changes 1 and 2, means that the high level is changes. In addition,
there is ST wave changes in lead 1 and AVL, speaks of changes in the lateral wall. At the same time, in the chest leads, we have RSR- pattern, but with narrow complex. It's incomplete right bundle branch block. With secondary T wave changes, which is physiologic with the right bundle. Heart rate, it's reasonable. It's in the range between 50 and 60. I don't see.
So I apologize for putting you on the spot, but there's also, look at the P waves and the AV conduction.
Yes, shallow P wave here in lead 1, but the best lead it's in lead 2 and V leads. I don't see the P waves here in the in V1, but there's in lead 2 P, and which is evident with very long PR, and the other beat, it's very short P. Means that there may be AV dissociation, and the patient may have nodal or junctional rhythm.
So she had syncope with a rhythm that's below.
In the lead,
That's a rhythm strip.
Yes.
Yes.
Rhythm strip, it's like
Torsade.
de point.
Yes.
The patient
So she had a high-grade AV block and developed torsade.
Torsade de point.
Okay.
Yeah.
So she had symptomatic complete heart block with torsade, and her echo showed some reduced LV function. So, sorry to put you on the spot.
No.
Yeah.
I was.
So should this patient have a workup for sarcoid? So she's young, and she has AV block that's symptomatic. So she should have some workup.
And she has no systemic manifestations?
She has no systemic manifestations.
Yeah.
And she would meet our provincial criteria for this. This is not funded regularly the way other FDG is funded. We have to go through special criteria and review, but she would meet those criteria. She had an MRI which shows some septal uptake, and she had perfusion FDG. You can see there's a little bit of reduction in perfusion in the basal septum, and there's hot spot in the anteroseptal, septal, and infraseptal wall. So does she have sarcoid? Maybe. Should she have a biopsy? Probably. So here's her whole body scan. So unlike the prior patient, there's no extracardiac lymph node uptake. There is an abnormality that I didn't pick up as a cardiologist, but our nuclear medicine physician picked up, is that her tonsillar activity is quite high, suggesting that she may have a concomitant viral infection. Okay? But we see the septal uptake as we already pointed out. So the question is, could this AV block resolve? Should she have a pacemaker? Should she have an ICD? Should she be put on steroids? So the uptake in the anteroseptal wall we already pointed out. She did have an RV biopsy because there was no lymph nodes to biopsy. And this showed lymphocyte infiltration consistent with myocarditis. There was no giant cell, and there was no microorganisms, and Lyme disease serology was negative. She was started on steroids, and we repeated the scan 20 days later, which would be a very rapid response for cardiac sarcoid. And lo and behold, her FDG uptake was completely resolved, as was her AV block. So the point here, and I'll be brief because I know the time has run out, but both cardiac sarcoid and myocarditis can present with ventricular dysfunction, heart failure, arrhythmias, AV block, minimal symptoms or significant symptoms and findings. If inflammation and scar can occur with both. In sarcoid, it tends to be more focal, but can be global. In myocarditis, it tends to be more diffuse, but can be focal. Systemic inflammation in sarcoid is usual. In myocarditis, it's unusual, except in the case of giant cell arteritis, and may require device therapies, cardiac sarcoid almost always when there's AV block and so on. And myocarditis, it depends on the course. And the use of immunosuppression, sarcoid we generally do, and myocarditis, it's controversial. So I'll stop there. Thanks.
Thank you. We have no more time, and this session is over.
Okay.